In this presentation, I am going to speak to you about how should you approach a patient who has been suspected to be having a renal injury. And this is a dominantly clinical approach which you utilize in emergency setting, where you have to work with lesser investigations and in limited period of time. The first thing that you need to answer to yourself when you see this patient, that is this patient actually having any renal injury? Next, you have to determine how severe is the injury, what is the grade of injury or what is the stage of injury in that patient. Third thing would be, in your approach, how should you manage the patient scientifically, appropriately, timely, and while you are managing the patient, what complications you should expect and when should you expect these complications. So in your approach to managing a case who is suspected to be having a renal injury, that's the way to go. I'll take these steps one by one. First of all, when should you suspect the presence of renal injury? You should know that renal injury does not take place in a very casual way. It does not happen to everybody. You will have to have a specific type of trauma to result in renal injury. God has given protection mechanisms to us. Our kidney is not vulnerable, it is protected nicely. But then there are certain individuals who get predisposed to renal trauma. So what I am saying is, when you have a particular type of trauma which happens to an individual who is predisposed to get renal injury, you get a situation of renal injury. Now I want to elaborate on these two things. What makes an individual prone? I may not be prone or you may not be prone, but there will be an X kind of guy with a Y kind of kidney who is more prone for developing injury. Age is the first thing to keep in mind. As a general rule, children are more prone to have injury of kidneys because there is less fat around the kidney and the skeleton is slightly weak, more malleable. The impact that comes from the back or from the front is skeleton malleable, so the tip of the rib can injure the kidneys. Build wise, those people who are tall and thin in the build, their kidneys tend to come low down from the thoracic cage and they are more in the lumbar area and more vulnerable to trauma therefore. Males are more likely to suffer from renal injuries as against women because in females the fat around the kidney is slightly more and this cushions the impact of the trauma, so they get less of renal injuries. And finally, a patient may be harboring a disease in the kidney which makes the kidney size large, and if the kidney size is large, it comes out of the protective thoracic cage into the abdominal side and then it exposes itself to the impacts. So if you look at this thing, age, build, sex and a pre-existing disease, you can have all these four things combined in one single individual. Can you imagine a tall, thin girl, 6 years, who is having hydronephrotic kidney? Right? So what I mean by pre-existing kidney is a kidney which is large hydronephrotic or a kidney which is polycystic. These kidneys are filled with water inside and they are like filled balloon. All of you in your childhood, when you walk with full balloon in your hand, you know how fragile it is. So you can have everything in one patient and that patient becomes really very prone for renal injury. In adults, you can have a large tumor in the kidney which is prone for injury. Moving on to the second part, I said in the beginning that for renal injury to occur, you need a very special way by which trauma should happen. And this could be either a direct hit on the body in the area where kidney is located, or it could be some indirect way of trauma whereby the pressure wave comes to influence the kidney and its pedicle. Let's see one by one what is this about. What is this direct trauma? Direct trauma is either a penetrating injury where something penetrates the body, either it is a firearm or it is a stab knife or dagger. These penetrating injuries have a small point of entry and they can enter the body to variable depths, right? So if you have a penetrating injury in the area of the kidney from front or from the back, the penetrating object will not only go to the kidney, but it can also go to a hollow viscera in the vicinity of the kidney, usually colon and duodenum. Okay. So with penetrating injuries, we have seen that there is always, or not always, sometimes and mostly, there is a co-associated hollow viscera injury. In a blunt injury situation, where a wider object hits the body of the patient, there, if the trauma is from the front or the trauma is from the back, it sends in pressure waves in the body. And these pressure waves will not only influence kidney, but it may also influence the liver and spleen. So we have seen that when blunt objects hit the body, the solid viscera, other solid viscera is also having a co-associated injury. The point I am trying to make, if you have a case of penetrating injury and you have renal injury, keep at the back of your mind a co-associated hollow viscera injury. And the same thing, when you handle a case who gives you a history of a blunt object injury, keep in mind that this case may not be having renal injury alone, may also be having liver injury if it is on the right side, on the spleen if it is on the left side. Also you should know that you can have combinations, double injury which means kidney and liver, triple injury which means kidney, colon and spleen, and greater is the number of organs injured, obviously more serious will be your patient. Let me for a while explain to you what I mean by trauma from the front. Now see, this is the kidney, and at the back of the kidney is running the rib transversely. The rib is running, it's the 12th rib. And the kidney on the left, you can also have 11th rib at the back. And if the impounding force from the front, like this way, the abdominal wall goes in, the viscera goes in, and the lower pole of the kidney tilts backwards. It kind of tilts, it hinges over the lower part of the rib. And from there, therefore, there is a transverse tear in the kidney. See what I'm saying? If you hit this kidney on the front, and in a lateral profile, if you look, this is a lateral profile of the kidney, and the back on the right side you see a rib running across it, and from the front the arrow is showing you the impact. That's the way kidney is squeezed against the rib, and that is what results, the tear. So whenever you have a trauma from the front, and if the kidney is squeezed against the transversely lying rib, you get a transverse tear. You should also know that that's the way the tubules drain the calyces. You can see the radiating tubules which drain through the papilla into the calyx. Now when a wider object hits the abdomen, wider means something like a football or a wider somebody sleeping, and a hard object falls on the abdominal wall. It's a wider surface, then the impact of pressure is quite high. This pressure goes in the renal pelvis, and from the renal pelvis, the pressure waves go through the tubules in a radiating fashion. And when this pressure wave goes in radiating fashion, what you get is this, a lacerated kidney, multiple tears. So that's the point I was trying to make. The trauma has to be very specific, and on the basis of the trauma, and we can always find about what kind of trauma occurred by the history that you take, maybe from patient if he is conscious and alert, or from the people who watched him at the time of injury. So what about trauma from the back? When you have trauma from the back, now the orientation is rib is superficial to the kidney, like here. And when you have trauma from the back, like this, there is a fracture in the rib first, and the sharp end of the fractured rib lacerates the kidney. It will penetrate the parenchyma, it will penetrate the pelvis, it will penetrate both, and you can have whatever is possible. And that is about the direct ways of injury. So direct trauma can influence the kidney from front or from back. And now is the time for me to explain to you what I mean by saying indirect injury. The indirect injury means is acceleration, deacceleration phenomena. This can be vertical. Vertical means imagine somebody sitting in chair vertically like that. And you must have seen the merry-go-round, right? Where people sit in merry-go-round and sitting, and the accidents take place when a cradle gets separated from merry-go-round, and people sitting in a cradle, they fall from height straight down on the ground, right? Or the other situation could be you are going down the stairs and you are in a great hurry, you run very fast up down the stairs and you slip. As you slip down the stairs, you fall on your buttocks, right? And look at this picture here. The moment you fall on your buttocks, the moment the buttock comes to rest on the floor, the spine continues to go down, so it comes at a rest, right? The spine gets rest immediately, but the kidneys which are located in front, they are attached to the mobile pedicle to the aorta. The spine in your body comes to rest, but the kidney does not come to rest. By acceleration, it continues to move downwards, right? For a while. And if kidney continues to move downwards for a while, there's a stretch on the renal pedicle. And you can have therefore tears at renal pedicle, either in the vein or in the artery, because of vertical acceleration, deacceleration phenomena. You can have this kind of phenomena in a lateral situation also. Lateral situation means you are sitting in a vehicle, for instance, and you're sitting like that, you're sitting face to face, one row of people there, one row of people here, and the vehicle moving in one direction, you're talking, right? And suddenly there's a head-on collision, impact. And your body is sitting in a vehicle, you continue to move. With you, the spine continues to move. And suddenly there's deceleration. So body stops, but the kidney and pedicle continues to move in the same direction in which the vehicle was speeding. And you get what is called by lateral acceleration, deceleration injury, and pedicle put to stretch. You can get, when pedicle put to stretch, the intima is torn, the media of the artery can remain intact. Intima is not so elastic, so it's torn, and you get vascular thrombosis. So friends, this acceleration, deacceleration somehow is a peculiar way in which you get so-called normal-looking kidney, parenchyma and pelvis, but badly damaged because of vascular insight. So if you ask me that what an individual determines that he will or she will get injury, first of all, and what determines whether will she or he get simple injury or bad injury. So what are the determinants of the degree of injury in the kidney? First of all, is his or her kidney vulnerable? And I told you in the beginning what makes kidney vulnerable, right? The age of the patient, sex of the patient, build of the patient, or whether the kidney was large. So what I mean is, on account of poor protection, the kidney becomes vulnerable, large fat, low-lying kidney, or on account of a pre-existing disease, hydronephrosis, polycystic tumors. So this is the setting which makes the kidney vulnerable. Say here, if you have a normal kidney, you need much more severe impact to result in injury. But if you have a vulnerable kidney, you need lesser degree of impact to result in injury. So the point I'm trying to make is, you have to keep this combo in mind. Combo means severity of impact and the vulnerability of kidney. And when you keep two things in mind, you know how bad injury could have happened. And let me explain to you what I mean by the differentiation in the severity of renal injury. Now this is the normal kidney which has its capsule and which has the perirenal fascia that line in the back. Now if somebody gets contusion injury or a small trauma and a small laceration or tear in the parenchyma, the bleeding occurs, remains confined by the tough renal capsule. Capsule is intact, it is not fractured, it is not broken. So the hematoma results underneath the capsule and the bleeding is tamponaded by the capsular integrity. The capsule restrains the further bleeding, and this is called a subcapsular hematoma. This hematoma or this injury is not communicating with the renal pelvis, as you can see here. So it's called non-communicating type of injury, and we call it grade 1. So this is the simplest and least thing that could happen to a renal. Grade 1, non-communicating subcapsular hematoma. If in that patient, by chance or depending upon the degree of impact, the capsule is also ruptured, then there is nothing which will stop the bleeding, right? The capsular pressure will not tamponade it. The bleeding will occur in an extra capsular space in the perinephric space, which is a much more commodious space. There is only fat, so there is a lot of space for blood to expand, and a hematoma results, which is called perinephric hematoma. This is also still not yet communicating with the renal pelvis. So this is called non-communicating type of injury, but now because hematoma is bigger, as a consequence of capsular tear, we call it grade 2. The third grade would be, again, non-communicating, but the size of hematoma is big. Because the tear was bigger, or the larger vessel was torn, or for whatever reason, hematoma is really big. So it's a grade 3 injury because of parenchymal laceration. So I hope you realize that in grade 1, 2, 3, there is a bleeding which is towards the periphery of the kidney, and nothing which is happening to the collecting system. But then there is a grade 4 injury where the tear is much more deeper. The tear is through and through the parenchyma. The kidney is bleeding both outwards in the perinephric space and inside in the renal pelvis. Now this is the patient who will have hematuria along with a perinephric hematoma. So grade 4 injury is the injury which is now taking a serious turn. In grade 4, you also include one more variety, and that's called traumatic arterial thrombosis. I hope you recollect that I mentioned to you acceleration, deceleration mechanisms of injury. And I told you in that scenario, the particle is subjected to stretch and parenchyma is torn more often than media or the artery. So it results in traumatic arterial thrombosis, and this variety is also included in grade 4. Grade 5 will be a situation where you have shattered kidney, multiple lacerations, big hematoma all around the kidney, lot of bleeding, lot of clots in the renal pelvis. So that is a big injury, lot of injury to kidney substance. Or as another type is included is when the pedicle is also torn. In the grade 4, the pedicle was thrombosed. In grade 5, the pedicle is torn. So you can have bleeding from the pedicle also. And this is the worst kind of injury that can happen to the kidney. Now also see that grade 4 here and grade 5 here, in both the scenario, the tear is communicating with the renal collecting system. As a consequence of that, not only the blood from the kidney parenchyma will go in the renal pelvis, but the urine that is produced by the kidney will go from the pelvis through the tear into the perinephric space. And you get what is called urinary excavation. So grade 4 and 5 injuries have, along with a perinephric hematoma, they have perinephric urinoma. So you have a combination of blood and urine around the kidney in grade 4 and 5. 1, 2, 3, only blood. You will recall this point when we talk about management. Now I told you so many options or so many such a spectrum of kidney injury that you can have from grade 1 to grade 5. The question that will come in your mind is, how do you diagnose this kind of renal injury? How do you know what is actually happening? Is it grade 1 or grade 5? How do you know is, first of all, you being a student of medicine and surgery, you should know what clinical methods do we have at our hand that we can employ to make a reasonable clinical diagnosis. So you have to have, first of all, in history taking, a typical description from the witness or from the passerbys that how was this man or woman injured. The typical mode that I mentioned to you, direct and indirect trauma. You can have blunt trauma, which influences the kidney. You can have penetrating trauma, which might have injured kidney. And this typical mode subsequently will give rise to a set of symptoms in the patient. These are clinical symptoms, and then when you examine this patient, you will have a set of physical signs that you as a doctor can pick in that body. And then you make a clinical diagnosis. Let me elaborate on this point a little more. What I mean, what kind of clinical symptoms you expect. You expect a set of symptoms that come in the urinary tract. After all, it's a kidney injury, and kidney is the part of the urinary system. And you have, therefore, have lots of symptoms that originate in the urinary tract. And the hallmark symptom is hematuria, the blood in urine. And mind you that the quantity of blood is not an indicator of severity of injury. You can have very small amount of blood and a very big amount of kidney injury. What is important is presence of hematuria, that's all. Don't relate degree of hematuria with degree of injury. You remember I mentioned to you grade 4 where there is arterial thrombosis, grade 5 where there is vascular pedicle torn. Suppose you have only vascular pedicle injury, you do not have any hematuria at all. Only some drops of blood, only some microscopic RBC coming in kidney because of congestion and ischemia. So don't relate degree of hematuria with the degree of injury. That is the first message. The second message is hematuria can immediately follow following injury. The patient has injury now, and 5 minutes later, the man passes urine with blood. This is called immediate hematuria. But you can also have a situation where injury occurred, minor hematuria happened, patient did not notice it, bleeding stopped, there was a clot formation, right? And the patient is okay, his small pain, that's it, moving up and about, doing his work, doing his job. 7 days later, 8, 10, 15 days later, the hematuria dissolves and bleeding re-establishes. This is called delayed hematuria. And this is also called hematuria tardive. Tardive means something which happens slowly. This is a peculiar way hematuria can present for an renal injury. And thus that means that whenever you suspect hematuria due to renal injury, take history of trauma immediately prior and you go back in time. Well, 15 days ahead, did you fall on the ground? Did you hit against the wall? Did you hit against the chair? Did you have an automobile accident? 15 days prior. So there are 2 things, that's why. The timing of hematuria, the degree of hematuria, again, do not indicate the severity. In some patients, when the hematuria is very brisk,
The bleeding is very brisk on the kidney. The blood travels down the ureter, and because of thickness of the blood, it makes a clot in the ureter. So the ureter lumen is obstructed by the blood clot.
ये रिकॉर्डिंग हो रही है.
And when you go and examine this patient again, you will have signs in the area of the kidney, the flank, the one side that is injured. The skin will show you bruise mark if it is a blunt injury, stab mark if it is a knife dagger injury, gunshot. You will get an entry, word of entry in the flank, from the front or from the back. When you examine, you get some kind of guarding, some kind of muscular tenderness, and you will feel a lump. And this lump could be tender lump because it has come up very recently and the blood there blood irritates the muscles and the tenderness is there. When you examine the lower abdomen of this patient, you may sometimes discover a bladder full of blood clots. Patient says, I'm not able to pass urine. I want to pass urine. You examine the bladder is full. And I mentioned to you that there will be some kind of paralytic ideas and you auscultate this abdomen, you will find absence of bowel sounds. So you get definite signs of renal injury and abdomen. If you don't get a lump, you certainly will get flank tenderness, right? You will examine the rib also, and you sometimes can detect tenderness at the rib tip because of a fracture there. Okay. And when you examine this patient systemically, I'm sure you should do, in fact, systemic examination earlier than the local examination. The systemic examination will show you tachycardia, drop in blood pressure, either postural hypertension, right, and maybe the patient said BP drops, or he can have a frank hypertension as a consequence of hemorrhagic shock. Depends upon what has been the time lag between the injury time and the time it is brought to you for examination. And depending upon the time, the degree of blood loss the patient had. But when you have that history and this examination which is expansion, and you now suspect reasonably that there is some degree of kidney injury, how do you confirm? You would, in emergency, of course, do an ultrasound of the abdomen. Here, I must tell you that you are doing ultrasound not only of the kidney, but please also see the entire abdomen. All other solid viscera, liver, pancreas, spleen, peritoneal cavity, what is present in the peritoneal cavity, what has happened to the bowel loops, and it's a pan-abdominal ultrasound, right? But here, I am mentioning here as ultrasound of the KUB to impress upon you, don't forget KUB, but at the same time, don't forget the neighborhoods. Ultrasound somehow is not a very good test when you have to pick smaller subcapsular hematomas or smaller size of hematomas. The tissue resolution is sometimes not very good. But then if you have bigger hematoma, bigger extravasation of the urine, larger tears, then you can definitely take one ultrasound. So ultrasound is a good tool to treat major injuries. Next in the line would be a radio imaging. Radio imaging methods will be either intravenous urogram or a contrast enhanced CT scan if patient can be shifted to radio imaging suite. If patient is stable enough that he's not in shock, he's not dying of renal injury, you have given him some management and he is stable now, shift him to radiology suite as soon as possible, and contrast enhanced CT scan of abdomen is the test of choice. Why you need to do this CT scan? Because this is a tool on account of which, or by the interpretation of which, you will be able to stage the renal injury or grade the renal injury into 1, 2, 3, 4, 5. This is the ultrasound picture of a patient who is having a subcapsular hematoma. This is slightly big, so it is compressed the kidney and the capsule is still not ruptured, something like grade 1. This is a CT scan of a similar patient who has a large subcapsular hematoma, kidney is compressed. You can see picture of the kidney on my left or to your right on screen. This is the number 1 there, by cross shown there. The parenchyma is buckled inwards because of the pressure of the fluid. This is a CT scan of renal injury, and here, top half of the picture, look at the liver. In the posterior part, you see a transverse tear in the liver. Okay, two, three tear lines seen running across the liver in the posterior part. Picture on the bottom, you will see liver laceration more clearly, and you will see something happening on the upper pole of the kidney. But if you see more pictures of the same patient, you would see the kidney normal, the other kidney, absolutely fine. The kidney on the right, you would see as if it is broken into half. One half going towards the abdomen, one half posteriorly settled with a transverse tear in this kidney. You would see picture on the top, because of the contrast enhancement, kidney parts are visible. A picture on the bottom, you will also see some contrast leaking from the renal pelvis coming into this perinephric hematoma. So what do you think? What grade of injury is this? Right? This grade of injury is communicating renal injury, obviously grade 4. And since the kidney is perfused well, the vascular supply of kidney is maintained. The injuries in the parenchyma, injuries in the renal pelvis, injuries in the liver, so it's a case of a twin injury because of blunt trauma. This is a magnified view of what I was talking to you. The upper half of the kidney is shown, the lower part of the kidney is shown. In the center part, you can see across the kidney there is an area of non-enhancement caused by the tear and by the hematoma. The kidney is surrounded by a perinephric hematoma. The other kidney looks absolutely normal. Right? So that's the kind of finding you can get on CT scan. And this is the accelerated contrast at the back of the kidney in the next cut. See, you can see the renal pelvis, you can see part of parenchyma, you can see this behind the kidney, layering of the contrast because of extravasation of urine. So friends, we would place CECT, contrast enhanced CT scan, as the test of choice for all patient renal injury, because it not only allows me to stage the degree of injury in the involved kidney, it tells me what has happened to the other kidney, is it normal or diseased. It also tells me what has happened to the liver, spleen, pituitary. So it gives me about the kidney as well as about the livers. So that's the test we want to do. But many times it happens, the patient is sick, serious, and cannot be transferred to radiology suite. In that scenario, you have to rely on ultrasound, you have to rely on clinical methods of diagnosis and act accordingly. Finally, how do you treat renal injury? First action should be to save the life of the patient. After all, the patient is injured in trauma setting and he may have risk to life. So first goal of treatment is to have a living situation, living problem. You have to treat shock of the patient. by volume replacement, get as soon as possible, draw blood samples, send for cross matching, transfuse plasma, renal active, whatever you have to do, see to it the BP is maintained. And you must also look for other injuries. And I mentioned to you that you can have thoracic injuries, you can have liver injuries, spleen injury, spine injury, and rarely head injury. And these are the ones which are more sinister. I would not say more sinister, but they're equally bad. And if you do not put your eye towards these organs and you miss that injury, focus only on renal injury, you will have a situation where you lose the patient on account of neglect, the thoracic injury for instance. So, when you are saving life, keep in mind both aspects, shock and other injuries. The next action would be, having saved the life by blood arrangements, shock treatment of hypovolemic shock and all this, excluding other injuries, the next in your mind should be to save the kidney. And when you want to save the kidney, of course, your first endeavor should be to initiate some kind of treatment, which is conservative treatment. And this conservative action would be, first of all, you put patient into the bed, hospitalize him, put him into the bed, complete, absolute bed rest. This is key. Second, sedate the patient. The patient will be anxious and in pain. To give him analgesics which are non-nephrotoxic. Give him antibiotics because blood is a good culture medium, particularly if it is loaded with urine also, right? So a hematoma which is having urinary salivation is very prone for infection. So you have to give him good broad spectrum antibiotics. Again, the antibiotics should be non-nephrotoxic, right? And you have to of course do appropriate volume replacement. Have a catheter in the urinary bladder to monitor urinary output. If there is blood in the bladder, wash the catheter, remove all clots. You have to be knowing what is the urinary output of the patient on an hourly basis. Once you initiated this kind of conservative treatment, you also stand by the side of the patient as a doctor and monitor the progress. Monitor the response of the patient to your treatment. And how do you monitor that? You monitor that by recording the vitals every 15 minutes, what's happening to pulse, what's happening to blood pressure, what's happening to respiration, what's happening to urinary output, what is happening to local signs, is the hematoma increasing, decreasing, is the hematoma pulsating, what is happening to the hematuria quantum coming in the catheter, increasing, decreasing. So you set your eyes on the patient. It's not like that. You examine the patient one, order the treatment, and walk off and see the patient after 3 hours. Never. Be by the side of the patient. You or your colleague or your nurse, you must monitor the patient, what is happening to the patient. Now, if your patient stabilizes under conservative treatment, you have time to do a CT scan. Remember, lesser grade of injuries will get stabilized. And you can continue conservative management, particularly in children. They stabilize very fast, and if you give them 24-48 hours of stable period, the injuries will be very fast. And you will be able to save the kidneys by only conservative treatment. In large number of children, in large number of patients, this is the package that you need to give and you get a good outcome. Third action would be that you are treating this patient conservatively, but your monitoring tells you that the patient is not improving. His BP is not kicking, his pulse is not improving, his hematuria is ongoing, his lump is increasing, his abdominal lump is pulsating, abdominal is pulsating. So you can have clinical setting where you have done your best for about 4 hours, 5 hours, but still the patient is unstable. What do you do in that setting? Now here is the indication to operate. All patients who following injury remain hemodynamically unstable, all patients who show expanding hematoma, all patients who show a pulsating hematoma should be subjected to surgery, right? Something like surgery. And actually, if I say subject to surgery or subject to some kind of intervention, your decision should be based on clinical indicators, as I mentioned to you just now, and the decision should also be based on a CT scan finding and the grading of injury that you have done, grade 1, 2, 3, 4, 5. If it is a single site injury and if it is non-communicating type, this means grade 1, 2 and 3, right? In this grade 1, 2, patient is usually stable. It's only grade 3 non-communicating where sometimes patients are bleeding in dilated space, and if they are low frame individuals, if the body build is such, their circulating volume is low, they are anemic from beforehand, they become sometimes unstable and they have to undergo what is called angiographic embolization. You can get away by interventional radiology trick and you can stop the bleeding from kidney and patient will be fine. But if a patient is having grade 4 injury, where you have single laceration through and through, outside in the cardiac space, inside in the collecting system, a single cut. This patient, and the hematoma is not too bad, not too big, the only cut is there, you pick up the patient in a matter of few hours. So this is the time, this is the scenario where we, the urologist, put a double J stent in the kidney. Take care that the urine should not exercate outwards in the diagnostic space. And then keep a catheter, manage the patient conservatively. There is a window of patients, there is a category of patients who can get away, who can be fine with this treatment. But remember, if in grade 4 injury, hematoma is expanding means you examine now, it is there, 2 hours later we discover bigger hematoma, right? Or you put a hand on the hematoma and pulsating. Pulsating hematoma means the pressure of the hematoma is such that it may end and rupture and create problems. So if the hematoma is big, expanding, pulsating, patient must undergo an operation like potentially by experienced surgeon. If you are not operated, if you are not witnessed kidney surgery of trauma, please don't hand on handy. Let somebody who is more experienced handle this case, have a lot of blood at hand, a lot of experience people at hand. Now, if the CT scan is showing the multiple sites of injuries, multiple lacerations, see, you can have shattered kind of kidney, you can have 2 lacerations, right? So you see how many lacerations you have, 2 lacerations, 3 lacerations. What is the hemodynamic stability of the patient? How is the condition of the opposite kidney? Can you sacrifice this kidney? The decision to sacrifice the kidney depends largely upon what is the condition of the contralateral kidney. Some patients have diabetic nephropathy, some patients have renal failure, some patients have solitary kidney, some patients have small contractile kidney. So please, before you decide how to do and what to do, keep in mind what's happening to the opposite kidney. If there are peripheral tears, you can expose the kidney, dissect the injury part and put this patch of momentum in the tear and do what's called renography. We have done away in some patients with this. So you sometimes may need nephrectomy. Kidney is shattered, very badly injured, other kidney is normal, do nephrectomy, quick nephrectomy, and that's important is to save life. Now you cannot save kidney, but you can save the life. And finally, some word about while you are managing this patient in your care by conservative treatment or by surgery or whatever stenting, angio be done. Patient with you for now 24 hours, 48 hours, 3 days, recovering. What complications you must keep in your mind that can happen in this patient? The complication that can happen to him, a set of complications can happen within short term. This means within a week. They can come up before you are surprised. Not a surprise, but they do come sometimes. They are called short-term complications or increased hospitalization. And they are hypovolemia, persistent hematuria, and the clots in the bladder leading to clot retention. You have to subject this patient to cystoscopic examination and removal of blood clots by cystoscopic methods, clot evacuation by electroevacuator. Right? The third could be the hematoma. Which hematoma? The one which is having extravasation of urine also in it, communicating type of grade 4 injury. There infection can set in the hematoma. This patient who was having till 3 days flank pain, discomfort, low-grade hematuria, some tachycardia, now starts showing fever with dry eyes. Pulse rate goes up, blood count, leukocytosis goes high. This is the patient who is not developing infection and hematoma, and he will topple very fast, very sick very soon. So you have to manage. And the other complication would be a secondary hemorrhage. Secondary hemorrhage means you admitted a patient, you did a conservative treatment, the injury in the kidney started showing signs of bleeding, hematuria stopped, pain stopped, patient became fine, his parentic IVs cleared, urine output maintained. Seventh day, eighth day, something happens, and you get a call, doctor, the patient is bleeding again, hematuria again. All this patient is severe pain in the abdomen, in the flank, because of repeat episode of bleeding. This is called secondary hemorrhage. And this occurs because of dislodging of the clot in the vessel. Okay. This is sometimes a complication which can quickly take the patient away from you. Very, very potentially fatal, mortal complication. On a long-term basis means you have treated the patient conservatively, the injured kidney is in situ, right? And you discharge the patient, the patient goes home, and you ask him to remain in your touch for follow-up, and you want to monitor how well the kidney has recovered, is it functioning kidney or not functioning kidney, what happened to this kidney. So when you put the patient in follow-up, some things bad can develop, like hypertension, or a complication called pararenal pseudohydronephrosis, or an aneurysm in the injured renal artery. The arterial wall became weak by trauma, it healed, and then aneurysm formed, or the entire kidney where vascular insufficiency occurred becomes non-functional following trauma. Let me explain you a little bit about these complications. Now look at this picture, which is showing you a communicating hematoma. The renal fibrous communicates to hematoma. The urine goes out into the hematoma, and as time passes by, there occur islands of hematomalysis. And in that hematomalysis, light fluid can form a cavity. Okay? And in that cavity, you will get abscess, infection. So liquefying hematoma is very prone for infection, particularly in communicative type. Some patients develop what is called delayed hypertension. Why do they develop? This is because of what is called cage kidney effect. What is the cage kidney effect? This is when you get, you see, there is a diagram showing you a hematoma through the laceration of the patient. And this hematoma goes in a subcapsular plane and goes all around the kidney, like that. Now this hematoma is all around the kidney, thin layer or a slightly thicker layer of blood is like engulfing the kidney from all sides, like a cap over the kidney. And then this hematoma stops and gets converted into fibrous tissue. And then this hematoma will start shrinking, it replaces fibrous tissue. As kidney is healed, and so does the hematoma heal, this patch of fibrosis all around the kidney will compress upon the kidney and make the kidney squeeze like you are squeezing a lemon. As if you have tied a cellophane cage around the kidney and you're compressing the kidney by the action, by the compression in the cellophane cage. This is experimental done in dogs. When the kidney is compressed by cellophane cage, squeezed inside the cellophane cage, this compressed kidney becomes ischemic kidney and causes hypertension. This is called cage kidney. And something similar happens here as a consequence of fibrosing hematoma in the subcapsular plane. That's what happens to the kidney. Small contracted kidney and patient gets hypertension. In some unfortunate victims, if the upper pole gets that kind of care and is completely isolated and get devascularized, this patch gets devascularized and gets fibrosed. You get a polar, upper polar or lower polar scarring, scarred pole, ischemic pole, and that's what causes hypertension. The point I'm trying to make, all patients of renal trauma without fail should be advised to get a BP monitoring. I would say 3 monthly should be fine. They must monitor their blood. So these days, patients will monitor the BP themselves. They need not visit doctors. The other complications are interesting, but rare. And my experience of about 2.5 decades of urology treatment, I have seen only 2 patients suffer. So you can know how uncommon it is. But it is somehow
पे कहाँ करो
very common with the examiners, and they ask you about what is this pararenal pseudohydronephrosis. And look at this diagram here, and this it's a communicating hematoma. The pelvis is communicating to hematoma. The urine is going out of the kidney pelvis into hematoma. And what is the difference in this patient is that hematoma has trickled towards the lower pole of kidney and has gone to the ureter.
ये
It is 5 sided ureter. It's juxtaposing the ureter. It is sitting
गाँव
over the
में है
ureter.
हाँ
Now,
खिंचा खिंचा के ले
this
आएंगे
hematoma gets dissolved
गाँव में
and no urine leaks into
आग
it.
लाओगे या
This is what is happening.
लानी पड़ेगी
Let's see the back diagram again. And see what is
खिंचवाने
happening.
वाला है
Back diagram again. And see what is happening. See the difference?
difference
Difference is the lower part of hematoma is increasing more. The one that is close to
करवा के
ureter.
लाइए अब मैं करवा
And
देता
the one that is close to ureter, now see the pelvis. Okay? In the diagram, see the calyceal system in the ureter. It's all right. In this diagram, see the ureter compressed and calyces getting dilated because
अरे उतने
the
कौन
lower part of hematoma compresses the ureter, causes high pressure in the
प्लान एक
pelvis.
साल बाद
Some hydronephrosis occurs.
पूछ रहा हूँ ऐसे
The kidney is producing urine. This urine now leaks
हम खिंचवा देंगे आप
from the tear into the hematoma,
बर्थडे बर्थडे हो
like that. So now, kidney is urinating outside,
और बताइए चले
and
मतलब
as
इतना नेट
the amount of blood collects outside,
नेट ना
hematoma fibrosis around the ureter becomes more and more severe.
ठीक है
You get this happening.
जाके बोलता हूँ
You get this happening. In times to come, perinephric space, all the hematoma is replaced by urine. And this is pararenal urinoma, which is because of the obstruction of ureteropelvic junction. Kidney is leaking urine outside, and now the dynamic balance sets in. Kidney is producing 500 700 ml urine a day, which is absorbed by the perinephric fluid space. So it's a dynamic balance. And this situation can exist for many, many years. Kidney can remain functional.
ओके थैंक यू
And there is a space around the kidney filled with urine. Pelvic system is dilated. This is called pseudohydronephrosis because the dilatation is not within the calyceal system. Dilatation is outside the calyceal system. It's called pararenal pseudohydronephrosis. This is rare, but this is important to remember. So thank you very much for your patience and listening to this lecture with me. And I'll be happy to have your questions and comments on my email. And I'll be happy to answer to you. Thank you very much.